Well, thank you. We're particularly excited today and this week for the Patient and Family Experience Week for 2019. Kathy and Martha, I think, is this our seventh year? And we've just had an amazing week so far. If anybody hadn't seen the panel, some of our former patients that are now employees that we kicked it off with, it was amazing. And I just have to tell you about one of the gentlemen who's a volunteer. It just really brought me back to earth in a way. He was, I think this was during the World War II years, and he had something that at the time was called Bright's disease. Does anybody know what that is? Dr. Fields, you're probably the only one in the audience that's old enough to remember that it's kidney failure and nephritis, and it was almost 100% lethal at the time. There was a doctor at Children's, though, that had this idea that if you gave blood transfusions, that might be able to overcome the disease. And so that's what was recommended, and I think I have this right. So he was admitted to Children's and lived here for 2 or 3 years and had 1,000 transfusions? 1,000 transfusions in those 4 years. Think about that. He was 3 years old, 6. The visiting rules at the time, his parents could come in, I think, twice a week for an hour, but couldn't stay. That's what they did. And he remembered that child life, that somebody took him into a closet and there were some puzzles and crayon in there. That's what he remembers. But he was the one in 1,000 that survived. And he has always been grateful, and he's fine. He recovered, and he went to work, had a family. And then when he had some time on his hands, he decided to become a volunteer here at Children's. John Bell, you might have seen him down there. He's a greeter. And so he told his story, and then he said he talked about the nurse that was his nurse in the hospital. And so when he finally went home, the nurse decided with her husband to buy a house next door to John's family so that she could take care of him at home. And so then his parents named his younger sister after her. And just think about it made me think, things like this are happening every day in our hospital. I mean, you people are doing things like this that impact those families and a person like John, way into the future. And you may not even know how positive that impact is. And we've learned so much about medicine. You think about 1,000 transfusions trying to start IVs on a 3 to 6-year-old at that time. Things are a lot of ways so much simpler now, but the intensity of the medicine, and the toll it takes on us, and that's what we're going to talk about today. And we just have an incredible speaker, an incredible doctor, and for me personally, an incredible friend. And that's Dr. Tom Lee. And you might wonder, well, how did an internist, cardiologist, superstar, just had this incredible career in Boston at Harvard, and is now, the chief medical officer with Press Ganey. And thank you to Press Ganey for helping us here at the hospital, but also with people like Tom. But he's a professor of medicine at Harvard Medical School, professor of health policy and management, all of these publications. But when I met him, you didn't know that was going to happen. He was on internal medicine, and I was a surgery resident. And we were side by side, and there was just such amazing camaraderie. And we would all meet together at the 10 o'clock meal, which wasn't really a meal, it was old tuna fish that they scraped up from the cafeteria. But we had such an esprit de corps and so much fun learning medicine and working together just through incredible, tough patients, demanding attendings. But I think it was that partnership that created a lot of friendships, and it certainly was that way for me and Tom. And, it's one of the things I treasure most about medicine is friendships I made along the way and caring for patients together, figuring out tough problems, writing papers about them, advancing knowledge, inspiring young people. There are just so many dimensions to what we do that sometimes we forget about. So I think it's particularly meaningful to have, for me, but I hope for you, to have Tom here because and as you'll see, he's just got this great way of communicating. He's done a lot of research on the issues like what it's like to be a physician these days and how we can build resilience, how we can get better, things we can do for each other. So with that, I'd like to introduce my great friend, Tom Lee. Tom?
No, it's a pleasure being here. And Kurt and I do go back. We go back almost exactly 4 years, summer when we were starting our internships together at Peterbilt Brigham Hospital. We were living like 50 yards apart, 75 yards apart in Brookline, but spending most of our time, at the hospital. I won't bore you with lots of stories from that era, though I could. I will just tell you that I don't ever recall Kurt sitting up front in an amphitheater. And I don't recall Kurt making it to an amphitheater, actually, now that I think about it. But he was a great colleague, and I will actually come back to that in a second. I'm going to talk about burnout, but I'm not going to take your time telling you about how important the problem it is. But I think we all know how important it is, or the toll it takes, the depression, suicide, that kind of thing. I think we all know that. But I want to talk about the path forward, and the path forward that actually is completely consistent with the other values that characterize this institution, values that are captured by these logos, these words. And I don't think they're in conflict. I actually think there's a common path that relies upon both great patient-centered care and also care that gives pride to clinicians to sustain them. It's not the only part of what we have to do for burnout resilience, but it is a part. And I'm going to work toward talking some about grit. Now, grit's not a word that we've used too much in healthcare. I wrote an article recently with Angela Duckworth, a psychologist at Penn, who many of you are nodding. She won the MacArthur Prize. She's got she has a big TED Talk and best-selling book on grit. So Angela's my cousin. She's 17 years younger. My brothers and I paid no attention to her sibling until she won the MacArthur Prize, and then she became my favorite cousin, and we're just like this. But we wrote an article about grit in healthcare, which I'll get to at the end, because I think at the end of the day, you don't take care of patients by yourself anymore. So gritty individuals, it's great to be a gritty individual, but it's tough to stay grit all by yourself. We actually need these people or teams that function like a macrocosm of a gritty individual. You need a culture that actually supports that also is like a macrocosm of a gritty individual. I actually think you've got all the ingredients, here at this institution, but I'll give you my perspective about how they fit together in the course of this talk, and we'll have some time to discuss it, I hope. framework for thinking about how things do fit together. I think probably a lot of you have seen this Simon Sinek TED Talk. I don't like to admit that TED Talks give you as much information as they do, but like they do. And this one is the use. Let me ask this: how many of you have seen TED Talk? Okay, so it's actually only about 20%. I'll say a little bit about it then, because it's the third most viewed TED Talk of all time, and a lot of you have heard what flowed from it. People talk about the why, the how, the what. And so it was 2009, and Sinek was interested in that question of why do some leaders, some organizations, or hopefully organizations like this one, why do they get the loyalty and trust and cooperation of people, and others not so much? And so he drew on a split chart at the beginning of the talk, 3 concentric circles, and he put why in the middle, and then how the next layer out, and then what on the outside. And he said most people, most organizations, they just focus on the what. What is it that we have to get done? That's all people are thinking about. That's all people are talking about. But he said the great leaders, the great organizations, they actually lead with the why. And that's what's most prominent in people's minds. And he contrasts most computer companies with Apple. So it's the heyday Steve Jobs. And most computer companies, they make computers. And they may get to the how, with their supply chain to make it faster. We will customize it to put in the RAM that you want, that kind of stuff. But Apple had a different approach, which is they led with the why. We're going to help you think different. We're going to help you challenge the status quo. Some of us are old enough to remember the first Macintosh commercial, the Super Bowl. A lot of you are nodding. Smashing the big screen to liberate the slave workers. The message was we're going to help you be different for you. The how of Apple was we're making things that are beautiful and intuitive and easy to use. And then the what was almost incidental. And what Sinek said was that people give their loyalty on the basis of the why, and because of the way it makes them feel about themselves. So, like Apple, like my oldest daughter, so President Brigham now, she's one of those people who lines up outside the Apple store the night before the new iPhones come out. And as Sinek points out, it's not because she needs the new phone. It's because of the way it makes them feel about themselves. And she likes to think of herself as I'm just one of those crazy people who lines up outside the Apple store. That's part of she likes that. Just the way you want people here to feel proud because they work here at the institution because of its why. In contrast, so like in Apple, I've got an Apple Watch, I've got an iPhone. Oh, sorry. I've got an iPhone, I've got a laptop, I've got an iPad. If Apple came out with a car, I would be checking it out. I'm sure many of you would as well. On the other hand, around this time, Gateway, the computer manufacturer, had come out with flat screen television. Some of us will remember that. And they were perfectly well equipped to make flat screen televisions. They were making low-cost flat screen monitors, but no one bought them. Because why would you buy a television from a computer maker? So there was no loyalty to Gateway that went beyond buying their computers. So Senek's point was people give their loyalty and their trust and their cooperation, their willingness to go along and do unexpected new things and deal with whatever happens on the basis of the why. Now, as far as I can tell, Sinek had no data. He just sort of had a way of thinking about things. We have a ton of data, Prescani, and we have looked at it, and it looks like Senek's right. We find, which I put on this slide, is we find that clinicians and other healthcare personnel, they give their loyalty to organizations based upon the why. They feel like it's here to do good things like take care of that patient like John Bell. Patients actually seem to give us the benefit of the doubt. They assume that we are here for the right why, and they give their loyalty based upon the how. And then our data indicate, an overwhelming amount of data indicates that if we get the why right in an organization and the how right in the organization, patients in particular, but also doctors, nurses, and other personnel, they will cut us some slack on the what. They give their loyalty on the basis of the why and the how. Let me give you some examples of that. So this isn't just rhetoric. This is actually based on data. So this is, and I've shown this figure before here in this auditorium. This was the first thing I did when I went to Prescani in 2013. I had done a lot of clinical research, clinical epidemiology research in my days when Kurt and I were working together, chest pain, emergency department, carry out risk assessment. And so this was applying some of those same statistical techniques to, risk stratification, but other kinds of risk, the risk that patients won't have peace of mind, for example. So this was a data set of 937,000 outpatients. Now this is adult, both pediatrics. We have repeated this in pediatrics, and it looks very, very much the same. I couldn't find that PowerPoint to put in here, but I've got it somewhere. So the question is, what seems to be the drivers of when patients don't give the highest level of recommendation, likely to recommend to the doctor and for the practice? So 84% do give a top recommendation, but 16% do not. Now, just to say, just to take it off the table, I know that patients' likelihood to recommend is not the same as, people in healthcare recommend someone. But I also know, because, they can't really tell who's technically excellent. On the other hand, I also know we can't tell who's technically excellent outside of our own little areas unless we're actually working with patients. And so I have some humility about likelihood to recommend in general. But what my colleagues and I, like a decade ago at Partners Healthcare, long before I came to Prescani, the epiphany that we had was that likelihood to recommend was actually an important outcome variable. It wasn't some reflection of service. It was an outcome variable. And the reason that happened was healthcare reform came in Massachusetts so fast in the rest of the country. And the pressures to become efficient came harder and earlier in the rest of the country. And as we started really working to try to become more efficient, we started having conversations saying, what are we trying to do? What are we trying to become more efficient at? And even though I don't know what dangling the participle or whatever preposition participle, I don't know. But I know that's not grammatically good. But you know what I mean? What are we trying to be better at? Because if you don't know what you're trying to accomplish, efficiency feels like it's some game where you're saying, what can I cut without creating a ruckus? And that doesn't feel very good. I'm sure all of you have been through budget processes that it feels like it's a game and you might be losing the game. So talking about what are we trying to do, that was pushed by the pressure to become efficient. At the same time, my colleague and friend from the Brigham, Atul Gawande, was finishing his book Being Mortal, and he had this epiphany as he was studying aging that we're the first people in human history for whom frailty is becoming a routine event. Most of us in this room are going to be living into our 90s, and we're going to get frail, and beyond 90s. And so when people are frail, you have to ask the question, well, what are we trying to do? What's the goal here? We can't just be doing what we do efficiently and safely. It's got to be something more like, what are we trying to accomplish? And so both Atul and my colleagues and I, we ended up in the same place. Partners, we were talking together a lot. And we have to be technically excellent, of course. We have to do what we can to help people stay alive and be healthy. But, we're not going to make people immortal. We do what we can. But then the real goal, the ultimate goal for every patient is that they should have peace of mind that things are as good as they can be, give them cards, they don't. That's the goal, peace of mind. And we felt that likelihood to recommend was the best marker for peace of mind. I can tell you we had this meeting at Partners where I joked saying, after someone said we're all going to die, most of us are going to go downhill before we die, and peace of mind to everyone. And I thought, that'll be a great marketing slogan for us. Peace of mind as you go downhill and die. They'll love that. But then people laugh, but that is what we're supposed to do. No one should leave here without peace of mind. So it was that led to a lot of interest in likelihood to recommend. So the big drivers of likelihood to recommend are the number one variable. This is a statistical approach to Pearson partitioning that takes a data set at every cut point of every variable and say what separates the data set into two groups with a maximum difference in the outcome of interest. In this case, failure to give a top recommendation. And you can see the number one variable is confidence in the clinician. On the outpatient basis, usually doctors, sometimes nurse. So they've got a high degree of confidence. You see only 1.9% do not seem to have peace of mind. You could dug a pretty big hole on the other side if they don't have confidence in the clinician. And like having your logo on white coats, for example, that's something that gives people confidence. Behaving like you're confident gives people confidence. But so good people is the most important thing, but it's not the only thing. Because the next variable is how well people work together. And you can see that if on the far right in the middle, if they feel like people are working really well together and that people are good, it's 1% of people who are not involved with their care, but an 11-fold increase if they feel like the teamwork is anything less than excellent. And then after that, same variable comes in on the other side of the tree. And then after that is a variety of forms of empathy and communication. And after that, there's nothing. Nothing else came in specifically. Waiting time for your appointment didn't come in. Waiting time during your appointment didn't come in. I mean, it's not nice to make people wait, and bad things happen when people wait. But in terms of driving peace of mind, which, as I said, is an outcome of care, what people seem to want are good clinicians who are working well together, who are showing that they care, and who are communicating. And our analyses in over and over in every sector, every age group, geriatric, pediatric, they look the same. Now, I also want to show you that these experience variables are not in conflict with how clinicians feel about their work. There is not a trade-off here. I could show you nurse engagement. I could show you non-MD, non-nurse, non-clinician engagement, and it looks the same. The physician one is actually a little more dramatic, which is why I picked it. So these are data for organizations where we measure both patient experience and we also measure engagement, both doctors, nurses, everyone else. And the circles, the rows are very patient experience variables, and the diamonds reflect the top quartile hospitals for how they rated the nursing care, how they rated the doctor care, how they rated the transition process and the likelihood to recommend and so on. And the bars over there in that bar column, that's a reflection of where they stood on physician engagement, where when we measure, we ask physicians, as we do nurses and everyone else, how do you feel about this place? Is it committed to quality? Is it committed to safety? How's the teamwork? All these engagement variables. Your likelihood of being there in 3 years. And you roll all those variables up into one single thing as a measure of engagement. What you see is that the circles are the lowest quartile hospitals in the patient experience as rated by the patient. The diamonds are the top quartile. Basically, what this figure means is that the physicians are much, much happier at the hospital with the patients feel like the care is good as well. So we all know that there are going to be some patients' families who are upset when they're being discharged early or something like that. I'm not showing you the relationship to left stay, but the same kind of thing with left stay. The correlations are actually, those are exceptions when you feel like there's a tension between patient experience and some other kind of value that needs something to do, like safety, efficiency. Overall, when you look at big data sets, trends will go together. These values are not in conflict with each other. A happy workforce is one that's associated with better patient experience, better safety, shorter length of stay, lower readmission rates. I can show you all these data. It would be, it would take up a whole lot of time. I can tell you that when my colleagues did the analyses, I think I kicked them off that I said, I think Chris Gaines should change the slogan to sophisticated analyses with more data sets to tell you what common sense should have told you long ago. But it's hard to be engaged when you're feeling burned out. So that's why I want to shift gears here and talk about burnout and what is the path forward. And it is not a single path forward. Burnout, my colleagues and I, particularly my brilliant colleague Deirdre Mylott, the PhD, who I consider both the brains and the heart of Chris Gaines in so many ways, she really is one who is deconstruction. And burnout is what they call a complex problem. I mean, some of you may have a framework. A lot of people use a framework. There are 4 types of problems. There are obvious problems where what you should do is obvious and just do it. And then there are complicated problems where multiple people must do multiple things. But if they do those things, they tend to be okay, like a critical pathway for doing, a simple operation. Complex problems are where there are multiple types of drivers that are contributing to the problem. And the one thing you can say about a complex problem is that there is no single solution. If you do one thing, almost surely nothing will happen. I think many of us in this room have tried to deal with a complex problem. We've done something and had our hearts broken when nothing happened. And that's because there are multiple drivers, and the one thing we're getting at, wasn't getting at the other. So it takes breaking down the drivers of a complex problem and then doing things to affect multiple drivers. The 4th category is chaos, which you're trying to get through a war, get through a complete crisis, just get through to the next day. Most of our big issues in healthcare that we spend time on are complex problems. So when you what you do with a complex problem is you break it down. So when we started to break down burnout, this is the framework that we came up with. We just published a little thing in JAM on this just a few weeks ago, a very short 2-pager, with this figure in it. And if you think about rewards and stresses and resting on a fulcrum, and I'm going to say right now, the fulcrum is not fixed in one place. The fulcrum can be far over to the right, so that, like when you had a surgeon like Kurt Newman, nothing, you would have tremendous stress, and nothing would, you wouldn't get wrapped. But that was Kurt Newman on a good day. Kurt Newman on a bad day, who knows? Fulcrum might be a little further over. But you think about there are rewards and stresses that are inherent to the act of taking care of the patient. And being in healthcare is great. You get respect. It has a lot of meaning. You feel good about yourself. You have some autonomy to what you do because what we do takes flexibility and adaptability. There are no quality measures that tell you the right thing to do for every single patient. So you take some autonomy and professionalism. It's a great thing to do, but it's a hard thing to do. That's where the stress is coming. You have to. Patients are suffering. Their families are suffering, and there are lots of patients who are never going to get better. You guys know this all too well. You can't fix everything. It can be pretty boring. There's a lot of work. A lot of stuff you got to do over and over again. You got to be checking all sorts of things, and there's tremendous responsibility. And if you screw up, the stakes are really, really high. Okay, so the first insight that came from breaking things down this way is that the inherent stresses and rewards are completely intertwined. You cannot decrease the inherent stresses without decreasing the ability of people to experience the inherent rewards. You can't say just don't let yourself feel it. Don't let it bother you when people are dying and their families aren't anxious, because if you do that, you're depriving yourself of the ability to feel noble on the other side of things. So what that means is, at that level, to maintain balance, you can't be like trying to decrease the stuff in the lower right. You've got to be thinking, well, what can we do to increase the sense of meaning people feel on the far left? And I'm going to give you examples. You're giving examples in what you're doing in the course of this week, the awards that you're going to be giving when I'm done, about building things up on the lower left. Now, on the upper level, there are different kinds of rewards and stresses that are not directly related to patient care. And, I mean, money is a nice thing. I mean, I like money. Everyone likes money. But, there are that's the upper right-hand side. But there are these stresses that are external, like, dealing with EMRs that don't quite do what you need to do. Just the, bureaucratic hassles and, confusion about what you're supposed to do next, trying to get medications into the hands of patients when the insurance company changes formulary. I mean, everyone here knows the kind of thing I'm talking about. The distinction between the stresses on the lower box versus the upper box, I would say, is when you, in the lower level, when clinicians and everyone else will go, this is what I signed up for. Dealing with people who are really, really anxious and so on. But for the upper box, those stresses, people go, I didn't sign up for this. Being unable to get something done that you need to get done. So that the insight for the external rewards and stresses that actually was one of our colleagues in Mayo Clinic who made this insight is that there's no connection between those upper boxes. You can't give more money to someone as a way of mitigating the frustration they might have about getting stuff done. They can't close the record in the EMR, that kind of thing. So that means that you have to focus real attention in the upper right-hand box. So like the two areas of opportunity so far I'm talking about are the upper right-hand box, the lower left-hand box. When we first showed this framework in the talk at Stanford, the CMO, he actually stood up and he slapped his hand to his forehead and turned to his colleagues and said, we are spending all of our time talking about the upper left-hand box, and the action is in the other two boxes. We're spending all the time arguing about money, titles, this kind of thing, and it's the other two boxes where the real action is. And then there is the fulcrum. The fulcrum is not fixed. It's not the same for everyone, and it's not the same in every individual. And the fulcrum moves based upon organizational cultural values. The extent to which people feel the why of their institution, that moves them over toward Christ. And an example I'll give was one of my colleagues, a wonderful woman, wonderful internist, goes to Guatemala every year, works for 2 weeks, squalid circumstances, 50 patients in the morning, no support, comes back, all sunburned, suntan, all, completely refreshed and happy. And then she comes and she practices back, around the corner from me in the old BEMA, the old Gen Center, now it's Gen Center. And something happens where, she can't find someone to, change the paper on the exam table or give a new paper on the exam table because everyone's clutched. And she starts yelling. So why is it that she flips out with a small thing when she's at the Brigham, and she can deal with anything? She can deal with fire and locusts and floods or something in Guatemala. And so she talked about it. She said, she goes to Guatemala, she's there because she chose to go there. She signed up for it. And she feels that what she's doing is something really good. And she says, in her job, she said, I feel like I'm a copy of a machine. I'm used to generate RVUs by a place that doesn't, they don't know what I'm doing. They're valuing the Nobel Prize winners. They're not valuing me. Now, I'm proud of the Brigham. I've been there since '79. The Brigham is not Enron, or it's not a crime family or something like that. It's a good place, but she's not feeling it. She doesn't feel that what she's doing, tracks up to something that the organization values. And so her fulcrum moves over to the left. So that where that fulcrum is, if you move to the right, that's enhancing resilience, enhancing your ability to deal with stress. That's what resilience is. It's not like, the opposite of burnout. It is your ability to deal with stresses so that you don't become burned out. So moving that to the right is what we want to do. All right, so I sort of giving you those three opportunities: upper right-hand box, lower left-hand box. Try to move the fulcrum through, and what comes right after my talk is part of increasing the lower left-hand box and moving the fulcrum over. But let me give you some examples from all three of those areas, and first focusing on the upper right-hand box. I know that that's not really the focus of today, of this week, but I think it's an important thing to do to counter burnout. I mean, one of the things I would say about burnout, before I go to these examples, is that if you just do one thing in an organization, you probably won't be completely effective. You may not be effective at all, and you might actually make people mad because it is multi-driver. And organizations get in trouble if they get the message. The problem with burnout is you. You need to be more resilient. You need to be in the moment, that kind of thing. You need a yoga mat. And another one of my colleagues flipped out when the Brigham Physician Wellness Group, which are good, smart people, they sent out an email saying, inviting people to a chair yoga session. And she was in a rage. She said, "I don't need a expletive yoga mat. I need 3 more minutes with every patient so I can feel like I'm doing a good job." She wanted the lower left-hand box more. So I actually do, anything you do in burnout, there's a risk that people think this is the only thing that you're doing. You think this is the problem. This isn't the problem. It's another box. So you have to actually show you're working in all 3 boxes. So that upper right-hand box is a big one. I mean, there's a lot of bureaucratic stuff and stuff that we didn't sign up for. And this is an example of a program that I like a lot. It's not the only example of the right-hand box, but it's a good one. Hawaii Pacific started a program called GROSS, GROSS, stands for Get Rid of Stupid Stuff. Now, I can tell you, in the first iteration, before they made it formal, that last S did not stand for stuff. And it replaced I'm not kidding, this is all true. It replaced a program called Bright Ideas, where anyone could email in a bright idea to hear better, and of course, no one did. They would get about 8 a year. So then they decided a year or two ago, we're going to repack this gross, and anyone can send in examples of work that was of little or no value or could be accomplished in a better way. And the example I put there was, I saw the email actually, and it was an ED physician. Most of them actually come. The biggest emitters are nurses and administrators. Anyone can do it, but nurses send them the most. This physician emailed, "Why do we print out discharge instructions and then scan them back into discharge?" And then put "why" in capital letters, exclamation point, question mark, exclamation point. Why? He was mad. And so the reason they computerized a process that was on paper, it made sense on paper, and then when you did it by computer, it became kind of stupid. It takes time to scan stuff back in. And like in the old days, when Kurt and I were trained, there would be triplicate forms with discharge instructions, and you give the patient, they sign it, and you rip off one copy and give it to them, and take 2 copies and put it in the chart. I never knew why it was 2 copies were put in the chart, but I did it. And so that's what was computerized. And so when the ED physician wrote this, the administrators go, Joint Commission makes us do that. And if someone calls Joint Commission, they go, "We don't make that." And they just put some box there saying discharge instructions given the patient. And so there are little things lot of them are really little, just like things you have to do with 4 clicks, for every shift, like about the umbilical cord, that kind of thing, that nurses have to do. But the result has been, first amusement. Everyone thought the title was cute. Mayo Clinic has a version of this called crap. For condescending, redundant, something. But it basically shows like, hey, you know what? Management actually has a little bit of a sense of humor. Management understands that there is a lot of stupid stuff, and it's committed to trying to work to remove it, and the work will never be done. So gross. We actually heard it presented at Prescani meeting in November of 2017, and I got the Hawaii Pacific folks to write. I do a lot of work in the internal. I got them to write a perspective piece, which was published last fall, and now it's actually being widely imitated. Cleveland Clinic just launched their version of gross 3 weeks ago, and exactly the same, calling it gross. Like the Brigham, where I work, the Harvard folks, they are tweaking it so it's their own little thing. They're going to come up with their own name. Cleveland Clinic just did exactly the same, and that's what the Brigham should have done too. So that's an example of the upper right-hand box. Lower left-hand box, socializing people, and giving people a chance to experience the rewards, talking about cases. Kurt brought up the 10 o'clock meal, the sort of sitting around talking about the cases you've seen. That's a lot of the rewards of being in medicine, your colleagues appreciating that you do a good job. And once you know each other in that kind of context, I can tell you that Kurt was a surgeon that we loved to call for a consult. He would never, ever complain, and he would do a good job. And he would never make you feel guilty for calling a consult, you pathetic, please, that kind of thing. There were surgeons who did. But that kind of interaction, a lot of us don't have it in medicine anymore, and there's a poverty from that. Like when someone behaves like that, you never want to point them as well. That's part of the report. So how do you bring that back on a systematic basis? Because medicines are so busy, so many people. It's tough to, there's a poverty in interaction now. People are really feeling that. One of the nice interventions that some of you probably know about, Mayo Clinic did a randomized trial of dinner clubs where they divided physicians into 2 groups. One group had more protected time. The other group went to dinner once a month in groups based 10 physicians. And they had to spend 10 minutes talking about a healthcare topic. The Mayo would pick up, no one was keeping stopwatch, and some of them didn't talk about it at all, but some talked about the topic the whole evening. But Mayo would pick up the bill to a certain extent. There was a $20 limit for, and alcohol is not included, but $20 goes a long way in restaurants in Rochester, Minnesota, I can tell you. I think there's only one in that place in the mall across from the hotel. At Meatloaf Special last time I was there. But it was good. But the impact was no difference in burnout in the group that had more protected time, but a 15.5% in one of the major areas of burnout in the dinner group. And so the result was that Mayo now says any physician can organize a group of other physicians to go once a month, and most physicians have there. The Brigham has just started this as well, and all I know you may be resilience, moving that fulcrum to the right. I'll give you 2 quick examples. It's the Cleveland Clinic empathy video. I think many of you have seen it. Made by our colleague Jim Merlino. He's from Cleveland Clinic to Prescani a few years ago. It was an internal training video to capture the values that should reliably characterize care, and it then went viral nationally. And it's no dialogue, just captions to reflect experience and emotion of the patient and caregiver. And the usual comment that was made the very first time was shown by Toby Cosgrove, and every time this is why we're here, and it's to help people empathize. Now, the thing I want to emphasize about this here is that to communicate values and build culture, you do that with stories. You don't do that with data. Stories like you're going to hear with your awards very, very shortly. But one of the brilliant things I learned from my cousin Angela is that shared stories, where everyone knows the same story, that's something that's very important for building culture. So that, like for example, how many of you seen this video? The no good video. Okay, so I can say to you, I still get choked up when the little girl pets the dog. And I see a whole bunch of you nodding. Some of you getting choked up. I can see you're tearing up now. And what that does when it's 1 minute into the video, you know that I respond to situations the way you respond. I have similar values. Then you can kind of trust me. So I have shared stories as a way of building culture. That is it's a very important, powerful vehicle. Another example of moving the fulcrum to the right, safety net institution, Grady Memorial in Atlanta, it was like on the road. It was on life support. Anyone here work at Grady ever? Okay, so when were you working at Grady? Okay, so that was like not in the crisis period. But it's always in a crisis. But like 10 years ago, they were on life support. Yeah. Tremendous quality issues, tremendous financial losses, incredibly bad engagement. If no one would stay there for more than 6 months or something. And they, there's this guy Matt Gove, who I consider the Don Draper of healthcare. He was, the mayor sent him in there to say what could be done at Grady, and he walked around for 2 weeks, and he came out at the end of that 2 weeks. He imagined this campaign, Atlanta can't live without Grady. And this is what I mean when I say he's the Don Draper. I'm assuming everyone here watched that. So this campaign, he told to anyone from Grady who worked there through the turnaround, and they said the campaign was a big part of it. First it got politicians, billboards, buses, some of these black and white photos of patients saying, I wouldn't be here without Grady. Celebrities, Tom Glavine, the baseball pitcher, black and white photos, red logo over his heart, saying can't live without Grady. And what it did is it helped everyone, internal and external, understand that Grady was important. Grady is a very important why, and made them feel more proud to be there. And their turnover went down. If you go on Glassdoor and read about Grady, you see people referring to the campaign about this is a stressful place to work, but this is a great place to work. So that's moving the fulcrum. All right, activation and burnout. So, we have, my colleagues at Prescini have, and as we got deeper into this burnout stuff, we realized that people feeling meaning was really important. So that, we now ask these 8 questions for an activation. Like my work I do, I have to make a real difference. My work's meaningful. 4 on decompression. I don't lose sleep. I can see online from work. And we've now asked those, and we can score people on activation, score people on their ability to relax. The analyses are really, really interesting that we have. I'm not going to dwell on the top part, basically saying all these things go together, patient experience, safety, engagement, so on. I already made that. The bottom part, what I wanted to say is that we have a study in press showing that when we work with Mayo to look at patient experience and then how activated physicians were, how much meaning they found in the work and their ability to decompress. And we found that patient experience was better in the doctors with more activation, the ones who felt more meaning in the work, the ones who would be more successful in that lower left-hand box. We also found a relationship with decompression, but was not the one we expected, not the one we wanted, frankly. We found that patients were less happy with the doctors who were better at relaxing. And at first we said that doesn't make sense. And then we thought, well, that kind of does make sense. What they want they want people who are maniacs for them. They don't care about our work-life balance. So what that means is that we can't make patient experience better by telling people never relax, don't cut yourself off. What we have to do is try to increase activation, increase sense of meaning. And that's why getting to these boards is so important. I sort of dawdled, so I'm rushing ahead here. I'm just going to focus on one point I want to make in the bottom part of this slide, that when we published something in Harvard Business Review last fall where we looked more at this activation data, decompression data for doctors, nurses, and then non-doctor, non-nurses. And the really cool findings we found is that for those non-doctor, non-nurses who are in healthcare organizations, activation really mattered to them. Like it really affected. It was a huge driver of their engagement with their job, their likelihood of saying they wanted to stay there, how they felt, how proud they felt. When you don't have direct patient contact all the time, you really appreciate the contact that you do get. So, an example of one thing an organization is doing to help bring more meaning to the non-doctor, non-nurses. My very favorite, Scripps in San Diego, they've started something called One Thing Different, where they encourage people to just identify one thing different they do to make patients lives better. And then they 3,000 of their workforce has responded, and then you can go online and see what did the social workers do, what did the escort service people do. Like one of the escort service guys, I saw a little video with him. He felt that when he brings patients back, if he brings them back to a bed that's made with the sheets smooth, it's somehow better than if the sheets all ruffled. So he just always makes the point of getting there a little early, smoothing out the sheets, making the bed, and he just feels like it's better. I actually mentioned this yesterday at the Bay State Medical Center, someone who trained with Mark Kerouac. I told him that, and he recalled someone who was a cardiology attending in our era, Tom Grayboy. He said, yeah, well, you remember that Tom Grayboy could have the patient sit up, and then before you have the patient lay down, he would always turn the pillow over and fluff up a little bit. He felt that lying down on the pillow always felt a little bit better. So that you can go to what are your colleagues doing, and it's leading to people discovering the meaning in their work. So that brings me to where I wanted to get to with grit stuff. And I think this is the transition to the awards. My cousin Angela and I, we wrote this article in Harvard Business Review in the fall on organizational grit because we know that healthcare in the past has thrived based on having gritty individuals. The Brigham hired Kurt, they hired me because we would never complain and would work really, really hard to do a good job. I mean, you still need people like that, but that's not enough. As it is, we can take gritty people and we can crush them with the complexity of healthcare today. You don't take care of patients by yourself. You need teams that function like macrocosm of gritty individuals. And you need organizations that nurture those teams, nurture those individuals, and are gritty themselves, trying to get better. We feel like the four major cultural ingredients for gritty groups, gritty teams, gritty organizations. The first is to have a goal hierarchy. And I know this slide isn't beautiful. This is from the HBR article. But a goal hierarchy is when you've got clarity on the bottom level goals, but you know how they track up to the mid-level goals, which are kind of like the how, which cares, the communication is good, the team is good, and so on. And they track up clearly to a high level, like reducing the suffering of patients. The second key ingredient is a growth mindset, the sense that we can get better. Even if we are the best, it's not good enough. We can get better than we are. And the third is a pride and resilience, learning from setbacks, learning from when you've been less than what you thought to be. Adaptability, ability to deal with the unexpected. And the fourth is strengthening your group identity, improving your, for an individual, identification with a mentor that you never want to disappoint, but at a group level, it's like identification with a team of people that you would never want to let down and respect means a great deal to you. So those are the four major ingredients. And we think that there are, in our article we talk about what it means to try to do this for individuals and for teams. But I'll just say that because this is an organizational meeting that we're having today, what we wrote is that the social norms and values that characterize an organization, having them be really, really clear, and having people identify with the why, that is a critical thing for having a gritty organization. I think you have all the ingredients here, and I'm optimistic of that. All of that having grit is something that will not seem foreign to you. It's just a new label for what you already have. So with that, I'm sorry I dawdled a little bit, but let me close, and I don't know if there's time for one or two questions or comments before we go to the next part.
Do we have any questions in the audience for Dr. Lee?
Thanks, Dr. Lee. That was a wonderful talk. My name is Sangeeta Sule. I'm in rheumatology. I just have a question for you about millennials, because we've been kind of given information that they may approach things in a different way and may not value the physician relationship as much as ease of availability to appointments or access. Have you noticed that in your surveys?
Well, I think that there are differences that I think that we all know. Millennials move around. They're less enslaved brand than they want things that are more convenient. This affects patients, families, a lot of issues. There are now more millennials in the workforce than baby boomers, so they are becoming dominant. One thing my cousin Angela says about millennials, and she studied them quite a bit, is that the major difference between them and us is that they're younger, and that as they age, they become more and more like us. They're better at you get tougher and you get grittier as you get old. She really feels that the difference are overrated. There's no evidence that they're less idealistic. They're, if anything, the evidence suggests that they are more motivated by some of the things that we're talking about, the award ceremony. They haven't been through that phase of medicine where money hypnotized everyone and getting, and the possibility of having enormous income, popped up and consumed a lot of people. They have different expectations, and they're every bit as much, if not more, here for the right reasons as